Welcome, everybody, to today's acid-base series talk. We're going to be continuing with metabolic alkalosis as far as its pathogenesis, and then some of the subtleties involved with both the generation and maintenance. And we'll continue doing this each week because it takes about 4 or 5 lectures actually to get through metabolic alkalosis. As I mentioned before, it's the most complicated pathophysiologically of the known acid-base disorders. And in addition to its complexity, there are a number of nephron segments and transporters that are involved that have become more understood in the last several years. But the literature on this acid-base disorder goes back at least to the 1930s, and several issues are still unresolved. So again, just this slide I showed before summarizes the changes in the acid-base chemistry. And you would think simplistically that the bicarbonate would go up and the chloride would go down, and the sum total of those two would remain the same. But as you see here, the anion gap also goes up a little bit in metabolic alkalosis because of the deprotonation of albumin. Remember, albumin is a buffer like bicarbonate, phosphate, hemoglobin. The histidines on all the proteins in your body, they're protonated or deprotonated depending on the pH. And when they do so, they change their charge. And so it's really the sum total of chloride, bicarbonate, and albumin and other anions in the anion gap that give you the total electronegative charge that roughly equals the charge on sodium. This again is overly simplistic because we're leaving out many ions and their charges, but just the take-home point is that the anion gap goes up slightly, not because we have organic anions like in an organic anion acidosis, but because we change the charge on albumin in particular. Okay, and then remember, like metabolic acidosis, you have a respiratory compensation. We don't just have the Winter's so-called Winter's formula or whatever formula you want to remember for assessing the compensation. The same thing occurs in metabolic alkalosis. We don't use the word compensation, remember, in the respiratory acid-base disorders, even though the bicarbonate does change over time in response to the PCO2. We divide that up temporally, but we do use the word compensation in both metabolic acid-base disorders. And the equation is different. As we said a number of times this year, it's 0.7 to 1 or 7 to 10. For every 10 change in the bicarbonate, the PCO2 goes up by 7/10 of that, or 70% of that. And this just shows you the data. People have plotted the bicarbonate and the PCO2 in a whole series of patients. And these are from different studies. And if you take the average slope, you're going to get a slope of 7/10 or 0.7 or 70%, whatever units you want to use. And then also remember that we divide up metabolic alkalosis by whether the urine chloride is normal or decreased. And the reason for that is we are predicting what the response will be to giving chloride to the patient. We give chloride to some patients, the metabolic alkalosis goes away. We give chloride to other patients, and the metabolic alkalosis does not go away. So rather than doing an experiment on your patient, you can predict what will occur by measuring the urine chloride. Probably better to measure the fractional excretion of chloride, because remember, the urine chloride concentration can vary with your water intake. You can double it just by cutting your water intake in half. And so you can be fooled into thinking the chloride concentration is normal and that they're not going to respond to chloride if someone's not drinking or has very little water intake. So the fractional excretion is better because it's independent of the urine volume and therefore your water intake, or the 24-hour or 12-hour urine chloride excretion rate. But then you have to know what the normal would be on that same diet. And that's always unknown or not as clear to fellows. So again, as we showed before, there's many factors that people have invoked as to the cause of the metabolic alkalosis. And when we say cause, we're talking about the generation, where the bicarbonate's coming from, and the so-called maintenance phase, why the kidney's not getting rid of it. And all these factors are complicated and confusing, and you pick your faculty member and they'll give you a different reason. And so there's a lot of experiments and studies that have gone on over the years. I'm going to review some of them today and cover some of these factors. And over the next few weeks, we'll try to get through this entire slide. So again, we have 3 phases that you have to understand clinically as a fellow, and as an attending. Generation phase, or in simple English, where did the bicarbonate come from? Remember, as we said last week, and we'll show again, the bicarbonate is not elevated because you lost water around a certain amount of bicarbonate. So don't use the word contraction alkalosis anymore, because that phraseology says really to someone who's thinking clearly that you have the same amount of bicarbonate, it's just that it's finding itself in less water, such as in a patient with diabetes insipidus, that sort of thing. And you never get a metabolic alkalosis in diabetes insipidus. So there's a nice experiment of nature showing you that the phrase is misleading. And then there are other reasons, as I showed last week, why it shouldn't be used. So the generation phase in clinical medicine means, where is the bicarbonate coming from? What vein in the body is adding bicarbonate to the blood? Then the maintenance phase, because the generation or the venous source is not sufficient because your kidneys are great at dumping bicarbonate. As soon as you go over the absorption of that roughly Arm & Hammer box of baking soda that I show all the time, the 3.3 or 3.4 moles of bicarbonate that the kidney filters and absorbs every day. When you go above that, the kidney just excretes the bicarbonate in the urine. Normally we have hardly any bicarbonate in the urine. The fractional excretion is very, very low. It's less than 1%. It's one of the ions that you don't find in the urine just because the nephron's absorbing it so efficiently. But if you go above a certain filtration load, you will find bicarbonate in the urine, just because the kidney doesn't absorb above a certain amount under normal physiologic conditions, unless you're volume depleted or your GFR is down or you have the sympathetic nervous system impinging on the proximal tubule. That will stimulate proximal tubule bicarbonate absorption and prevent the bicarbonate from coming in the urine. But under normal physiologic conditions, you go above a certain amount, such as just giving a load. If I start a bicarbonate IV, it's going to end up in the urine. So you have to have a reason for why the kidney is not allowing it to go in the urine, and that's called the maintenance phase. And there's certain things going on in the patients that prevent the kidney from getting rid of bicarbonate normally. And then there's the correction phase, when an MD comes along and does something. There's physiologic changes that occur that allow the bicarbonate to then get into the urine. And also, you may be doing something that shuts off the bicarbonate load, like you might stop the patient from vomiting, so their gastric vein is not going to be pumping bicarbonate into the IVC anymore. So again, these factors are not just associated with metabolic alkalosis, but these factors come into play differently depending on whether you're talking about the generation phase, the maintenance phase, or the correction phase. So it's even more complex. There's a whole matrix of factors depending on which phase of the metabolic alkalosis you're talking about. And again, in the generation phase, think of the source of bicarbonate. It's an amount of bicarbonate in a given volume of water increases. The loss of water around the same amount of bicarbonate, or a so-called contraction alkalosis shown in B, is just not something that occurs medically. So from this day and onward, if you can, both for yourself and tell your colleagues to stop using the word contraction alkalosis. Now, the maintenance phase, again, is you have to come up with mechanisms for once you've had the load, for why the bicarbonate's not being excreted. If you just focus on the red arrow, what you see here is a plot of the plasma bicarbonate concentration and reabsorption and excretion. It's sort of a confusing slide, but and the units are in microequivalents per mil, but it could be milliequivalents per liter. You just multiply each of these by 1,000. But what you see here is when you go over 24, you start getting bicarbonate coming out in the urine. The excreted is just look at the dash curve. These are under different volume states, so it's a bit confusing. But you can see that below 24, you don't find any bicarbonate in the urine. It really is above 24 that you start getting excretion. So then the question is, if your patient is above 24, why is there no bicarbonate in the urine? Why aren't they excreting it? That's what you have to answer for the maintenance phase. So as far as the generation phase, there are many, in clinical medicine, there are many, many sources of bicarbonate. It could be an exogenous bicarbonate load that an MD gave, or the MD could be giving citrate, Scholl solution, or acetate in TPN, or lactate in PD solutions. Those organic anions, citrate, acetate, and lactate, which have carboxyl groups, the carboxyl group, when it's neutralized in your body, is turned into bicarbonate. So there's all these exogenous sources. Then there could be endogenous sources. You could have a transcellular shift. Potassium hydrogen exchange actually generates bicarbonate in the extracellular fluid. When protons go into cells and potassium comes out, that actually generates one bicarbonate ion in the extracellular fluid. So you acidify the intracellular, but you alkalinize the extracellular. So transcellular shift of protons in exchange for potassium. Endogenous sources, these organ sources, it could be a renal endogenous source where the kidney is generating new bicarbonate, and that could occur in a number of places in the nephron. This is above what the kidney absorbs. The kidney, remember, every day generates around 50 to 70 milliequivalents of bicarbonate to match your daily hepatic proton load from the meat and the fish that you're eating. You generate hydrochloric and sulfuric acid, and the kidney compensates for that by generating an equivalent amount of new bicarbonate and putting it into the renal vein. If that is above normality, such as in Bartter syndrome and Gittleman syndrome, all the chloride-resistant metabolic alkaloses that are due to the renal causes, those are associated with excessive new bicarbonate generation. It's the kidney that's the source of the new bicarbonate, not the stomach or the colon. And it could be a renal endogenous source also, where bicarbonate secretion decreases. It might not be only that there's new bicarbonate generated, the kidney may decrease its bicarbonate secretion. It could also be a GI source from the stomach or the colon, as we talked about before. And then contraction alkalosis very, very, very rarely is a possibility, but that really is so rare and so minimal as far as its quantitative importance that it can be almost forgotten. So remember, in the maintenance phase, the plasma bicarbonate concentration is 25. Let's say you're filtering 144 liters a day. The normal GFR is about that. That would end up being about 3.6 moles of bicarbonate a day. When you multiply these two things, are coming through all your glomeruli. And the urine only has 10 to 20 milliequivalents. I mean, it's a fraction of this filtered load, which tells you the nephron's absorbing all of this. And so you're only going to get bicarbonate in the urine when you exceed this by giving bicarbonate IV. So when this goes to 26, 27, 28, it's going to be dumped transiently. It's not permanently, but if you transiently elevate this bicarbonate such that the filter load goes above this, the nephron's not going to absorb it. It's going to end up in the urine. And remember, if the kidney did not absorb this amount normally, you would be dumping all this normally into the urine, and in about 4 hours, your bicarbonate would be 0 in your blood. So this process is essential for the normal maintenance of a bicarbonate concentration of 25. So the maintenance phase has a number of potential changes. Either the filter load exceeds the ability of the kidney to excrete. You could have decreased GFR, so you have a normal concentration of bicarbonate, but there's just the filtered load is less. Well, there's less that's going to be going into the rest of the nephron. That's going to decrease the kidney's ability to get rid of bicarbonate. So if you give a load of bicarbonate, let's say, I don't know, 400 milliequivalents to someone with a GFR that's normal versus someone with CKD stage 4, for the same load, the blood bicarbonate concentration is going to go up much more as your GFR decreases. And someone with the ESRD would be the extreme. You give them the same amount, 400 milliequivalents of bicarbonate, the blood bicarbonate is going to go up even more. So it depends importantly on the GFR. And then also you could have changes in the bicarbonate absorption in the proximal tubule, thick ascending limb, or connecting tubule in CCD, where bicarbonate's absorbed. The major amount is here, around 80 or 85%, around 10 to 15% in the thick acini limb. This is around 2 to 5%, and the urine has 0 normally. But if any of these is stimulated, that's going to allow, if there's more coming through the glomerulus where the tubule would normally dump it, if these are stimulated, you're not going to dump it, and that would contribute to the maintenance phase. And lastly, you could have decreased bicarbonate secretion. Bicarbonate is secreted here in the connecting tubule and CCD via this protein called pendrin that you may remember. It's mutated in a disease called Pendred syndrome, and it's a thyroid disorder because the same protein is responsible for iodide uptake into the thyroid, but it's also present in the CNT and CCD in the nephron, where it exchanges one chloride ion for bicarbonate. It's not transporting iodide in the kidney. So again, the sources for the chloride-sensitive metabolic alkaloses are either stomach, and here's the transport machinery that we've gone over before. This is also responsible for the alkaline tide, the parietal cell. For every proton secreted into the lumen, one bicarbonate ion goes into the gastric vein. Or you could have the large intestine involved in a number of diseases affecting the large intestine. Congenital chloroduria is a large intestine diarrhea, and they get a metabolic alkalosis. But you can also have sometimes inflammatory disorders, colitis in the intestine, where these transport processes are perturbed, and you end up with a metabolic alkalosis. Remember, small intestine diarrhea causes a non-GAP metabolic acidosis, and you can distinguish where anatomically the diarrhea is from just by looking at the acid-base disorder in your patient. So again, the hypothesized factors involved. Today, we're going to be focusing on another two of these, hypokalemia and K depletion. And remember that we're going to be talking in part about renal causes, renal sources of the metabolic alkalosis, not the stomach or the large intestine. Now, remember, every day this idea sort of fits into this whole body balance that we've talked about before, where every day your liver is pumping in about 50 milliequivalents of protons in the form of hydrochloric and sulfuric acid from the cysteine and methionine and arginine and lysine hydrochloride amino acids that we ingest in meat and fish in particular. Remember, we have a whole dietary range of whether the diet is producing acid or base, depending on the type of food you ingest. But on an average North American diet, we make about 40 to 50 milliequivalents of protons a day. That can't be continually occurring, or your blood bicarbonate after a couple of weeks is going to be 0, not because you didn't absorb it, but because you got a proton IV going on every day in all of us, and we have to have something to compensate for it. And what happens is the kidney is the compensator, and what it does is it injects new bicarbonate into the renal vein that then, in a whole body sense, binds to the protons, creates carbon dioxide that our lungs get rid of. But if for some reason this renal generation is exceeding what is needed to match the daily hepatic proton load, then the kidney becomes a source of bicarbonate. And that's what's occurring in Bartter syndrome and other causes of metabolic alkalosis that have a renal generation mechanism. Now, remember, you'll see these kind of terms both on your exams, and people will talk about it in textbooks and papers, where there's something called renal net acid excretion. Some people look at this not being as bicarbonate being added to the body, but as the kidney getting rid of these protons. It's basically saying the same thing. It's preferable physiologically and biochemically to not talk about the kidney getting rid of protons in the form of ammonium and titratable acid, but rather that the kidney is generating new bicarbonate. But they're both equivalent. They're not additive. When you say the kidney is getting rid of acid in the form of NH4 plus and titratable acid, which remember is protonated phosphate, H2PO4, you're saying the same thing, because you have an equivalent amount of new bicarbonate being added. It's just better to think of the process as bicarbonate being added. Quantitatively, we can't measure that clinically, but we can measure these substances, ammonium, titratable acid. We don't measure TA normally in the clinical practice, but you can infer what it is from the phosphate excretion. We won't do that today. And then you measure the bicarbonate in the urine, add these two, subtract this, and you end up with a number, let's say it's 40 or 50 milliequivalents a day. That's how much new bicarbonate the kidney was adding. And normally we're in balance. We can't measure this. We don't have a way of measuring this clinically. We can measure other things in the urine that will give us this indirectly. But if the plasma bicarbonate is not changing, and this is the same every day, you know, the proton load is roughly the same every day. That's obviously the ideal world, because every day our proton load is changing because we change what we eat every day. But the kidney matches that. Now, if the new renal bicarbonate generation, shown here with this red bold arrow, exceeds the proton load, you're going to add bicarbonate to your blood in a net sense. And that's really what is happening in the generation phase of anything where the kidney is the cause of the generation of the metabolic alkalosis, and the vein is the gastric vein, or excuse me, is the renal vein, unlike vomiting, which is the gastric vein. So let's now go to the role of potassium. And it fits in because part of the mechanism for how potassium is thought to do it is not via the stomach or the large intestine, but via the kidney. So depletion of potassium is one of the pathophysiologic factors frequently considered. If you talk to many attendings and you say, what's the cause of the metabolic alkalosis? Many of them will say, just sort of flippantly, hypokalemia. Some will say potassium depletion. Those are very different. Hypokalemia and potassium depletion aren't the same. So you'll hear both of these being mentioned. And it may or may not be true in a given patient, as we'll show now. Now, there have been studies done looking at this much more stringently in animals and humans. And the question then comes up from these studies, can potassium depletion cause or sustain a metabolic alkalosis in the absence of aldo or high mineralocorticoid state, in the absence of depletion of body chloride, in the absence of ECF volume depletion or changes in the GFR? We'll answer some of these now. And just to summarize everything that's been done until this point in time, there are conflicting results showing that potassium depletion by dietary potassium depletion, because you can obviously create potassium depletion other ways with dialysis or through the GI tract, other ways. But dietary depletion, there's either no change in the plasma bicarbonate concentration, or a very small change, or a slight decrease. And in rats that have been studied, a metabolic alkalosis has been reported by some, but not all investigators. And in dogs, you actually get a metabolic acidosis when you potassium deplete through the diet. So I'll show some of these now. This is a study from 1974 in dogs where they dietary K deprived the dogs. And what you see here, if you look at the bicarbonate, so this is the control period, this is the potassium excretion. In the dietary K deprivation, as you would expect, the urine potassium excretion, each of these bars is 1 day. Decreases to very low levels because there's less potassium coming in the diet, and the bicarbonate actually falls. So that's sort of interesting. When you go back to a normal K intake, the bicarb goes back to normal. And what they measured here was the net acid excretion, which again is, you can think of as the bicarbonate added to the renal vein, just conceptually. And what you see here is that in the potassium deprivation period, the net acid excretion actually decreased. And so the patients are actually in positive acid balance, assuming the proton input is the same, or the dogs, excuse me, are the same. So there's this, assuming there's the same proton input from the diet, there's less protons coming out into the urine. So the dogs actually have a mechanism for getting metabolic alkalosis. Less protons in the urine, less new bicarbonate generation. So that they interpreted as the mechanism. And that was sort of not expected, because hypokalemia in any clinician's mind is always associated with metabolic alkalosis as far as the cause of the bicarbonate going up. And the net acid excretion was associated with less ammonia in the urine and less titratable acid excretion, the two mechanisms that some people like to look at as the mechanism for proton excretion. But as I said before, this is synonymous really with new bicarbonate generation. And when you see these decreasing, you have less bicarbonate generated. In humans, Sebastian's paper, Jones was a renal fellow at the time, did this study where they took, this is the first systematic study of humans. There was sort of a lot of other anecdotal things done before, but what they did was they had patients on a control diet and then a K deprived diet. And what you can think of it, you can deprive K a couple of ways. You could either remove potassium chloride, but then you're also changing the chloride concentration. You can't just, when you get a little more sophisticated and you think of changes in the diet, you can't just remove a cation or remove an anion. Otherwise, the diet is going to spark like a battery. You have to maintain electroneutrality in all solutions. And so when you either remove potassium, you either remove it as the chloride salt or some other anion, or you have to do a potassium, sodium, or other monovalent cation swap. And that's what they did here. What they gave the patients above the regular low electrolyte diet potassium or sodium phosphate that they swapped for potassium phosphate at different points in time here. So they had potassium phosphate, and then the K deprivation period, they went to sodium phosphate. So it's still not perfect because they're changing the sodium intake. But unfortunately, in human studies, you can't do it any other way. But you always have to think about these things when you're critically evaluating a study. Hopefully during your fellowship, you won't believe, 70, 80% of the things you see in print without first thinking very deeply about what the methodology was. Otherwise, you're going to be modeling the world when you become an attending based on data that you really shouldn't bring into your clinical view of the world. So this was the best study done until then. But again, just because of how you have to do this, you're either going to remove chloride, which has its own issues, which they didn't do, or you're going to swap with sodium, which they did do. So what they found was when they did this, you can see here the urine potassium excretion rate obviously fell again because the diet potassium decreased. Again, each of these is 1 day. And you can see after a while you reach a new steady state, and the blood potassium fell about 1 milliequivalent per liter from 4 to 3. And then this panel here shows what happened to the bicarbonate. You can see here the bicarbonate concentration did go up. It went up by about 2. So it didn't go up by a lot. And the pH fell, or the hydrogen ion concentration fell. pH went up, as you would expect. And what they found also, interestingly, which wasn't expected, is that the urine chloride excretion fell. So the patients actually went into positive chloride balance because their chloride intake was constant, but the urine chloride fell. Now, why that occurred, they hypothesized maybe it was because there was less K coming out into the urine. Not clear, but the chloride did fall. There might have been an effect retrospectively on pendrin, but that's a topic for another day. Because the chloride fell, actually the chloride concentration in the blood went up a little bit. Don't typically see that because there's effects on water, which should keep the chloride concentration the same. But at any rate, the plasma chloride concentration went up and the body weight went up. So it looked like the patients were retaining some volume also. And they measured the creatinine clearance. The control was 129. It actually increased during K depletion. And the aldo went from 14 to 5.2. Remember, aldo is very sensitive to the potassium concentration. And so this occurred with a low aldo, with volume expansion. So interesting things that were occurring that we typically sometimes, and with a higher GFR, all these factors that would tend, if they were in the opposite direction, there was a high aldo, low GFR, volume depletion. Actually the opposite occurred, and yet the bicarbonate concentration went up. So the bottom line from this study, which is the one really to refer to on a normal diet, is that in humans on a normal sodium chloride intake, the change in bicarbonate due to potassium deprivation is minimal. Bicarbonate hardly changed. And the increase occurred despite a decrease in net acid excretion or a decrease in new bicarbonate generation. assuming that the proton production rate was constant. And this increase occurred despite the creatinine clearance going up, weight gain, positive chloride balance, drop in aldo. All things that if they were in the opposite direction, we would think would contribute to the. So the bottom line then is if it doesn't appear that the kidney could have been the cause, because again, the net acid excretion decreased or new bicarbonate generation decreased. What is the source of the bicarbonate? Then they went on, Sebastian and his group went on to, Sebastian is the doctor, by the way, who came up with the terms, type 1, type 2, type 3, type 4 renal tubular acidosis when he was training as a fellow, and Curtis Morris was the faculty member. So they also were involved with this study. And they then looked at the effect of changes in sodium chloride intake on the severity of potassium depletion induced metabolic alkalosis. So what they did here was they had two groups of patients. They had the same degree of potassium decrease in their diet. I won't get into the complexity of the protocol here, but they had two different sodium chloride intakes. One group that was on a constant intake of 1.8 millimoles per kilo per day, and the other that very sodium chloride restricted intake. And then they looked at the effect on plasma K and also the effect on cumulative potassium balance. In other words, the potassium in the urine every day compared to the intake. And there were minimal differences in the plasma K. Initially, there were some, but minimal. And the dark circles, by the way, are the low sodium chloride group. So there was a difference, at least in these two. But more importantly, let's look at the bicarbonate. And what you can see here, this is the plasma bicarbonate. In the low sodium chloride group, the plasma bicarbonate for the same K depletion went up a lot more, went up by 8 milliequivalents per liter, whereas people on the normal sodium chloride intake, like the previous paper, had a very minimal change in bicarbonate. So what this showed is that potassium depletion per se is not a predictable parameter as to what will happen to the bicarbonate. It depends on how much salt you're taking in. And the lower the salt you're taking in for a given amount of K deprivation, you're going to get a higher plasma bicarbonate. Then they looked at the change versus the cumulative potassium deficit, because the deficits were different. The patients on the low sodium chloride intake for the same potassium deficit had a higher bicarbonate. It's just showing the same sort of thing, but now factoring in, making sure the potassium deficit was the same in both groups. So at any potassium deficit, there was a much bigger change in bicarbonate. Then they also looked at the net acid excretion. And what you see here is that the low salt diet actually increased their net acid excretion or increased their new bicarbonate generation. Whereas the patients on the normal diet, as shown in their previous paper, actually had a decrease in net acid excretion, or saying the same thing, a decrease in new bicarbonate generation. So for this group, we're still left with the question, where did the bicarbonate come from? In this group, with the increase in net acid excretion or new bicarbonate generation, at least we have an inkling that this may be in part due to the kidney, because the kidney is generating more new bicarbonate. And so the bicarbonate generation, this study also showed, is very dependent on your salt intake, association of things that people typically didn't think about before and still don't. They also looked at the chloride excretion in both groups, and you can see that in the patients that were on the low salt diet or the high salt diet, there was a much greater decrease in chloride. Okay, this is the 24-hour excretion rate, whereas on the low salt diet, the chloride excretion rate stayed about the same. So there was also a significant difference in chloride balance. The patients on the high salt diet actually gained chloride, a lot of chloride, more than they had on the normal salt diet. So a lot of things are occurring here, again, making it complicated to try to interpret. So just some take-home lessons. If an attending or someone asks you about potassium or K deprivation on a normal salt diet, it's minimal, the metabolic alkalosis. Whereas on a low salt diet, you get a much higher increase in your bicarbonate concentration. And the severity correlates with the severity of the potassium deficit. I didn't say that, but it did in their paper. And since net acid excretion increased on the low salt diet, or in other words, bicarbonate generation increased on the low salt diet, that means the kidney was at least in part responsible for adding more bicarbonate to the ECF. So the renal vein was in part responsible. Was it the only source? We'll see in a minute. We have to go through a little bit of complicated math. What are the other possibilities? Well, the urine chloride concentration and excretion. The low salt diet, the chloride was 0.48 versus 51 on the high salt diet. Remember that pendrin is affected by the chloride concentration in the lumen. And so maybe the low salt diet, there was less bicarbonate secretion because pendrin won't work when the chloride is very low. They didn't think of that. They didn't know anything about pendrin back in those days, but in retrospect, that this might have been affecting things too. What about the body chloride content? Well, on the low salt diet, there was some chloride retention, but on the high salt diet, the patients gained about 470 milliequivalents by the end of the study when you calculate basically the intake of chloride minus the urine. Every day it was positive, and you just add all those positive results together to find out what the total chloride balance was by the end of the study. Aldosterone also differed. Control was 100. On the low salt diet, it was 14. Remember, both groups are hypokalemic, so that's why the aldo will drop. But the aldo also depends on renin. So on the low salt diet, the aldo is a bit higher than on the high salt diet. But again, aldo could be affecting the difference here, because on the low salt diet, they had a higher aldo, and that could have been affecting the bicarbonate concentration. And then the creatinine clearance was different. The low salt diet had a creatinine clearance of 110, and the high salt diet had a creatinine clearance of 122. So maybe on the low salt diet, it was hard, even though it's normal, it was harder for the kidney to get rid of bicarbonate. So let's go back to that very first study where the net acid excretion and therefore the bicarbonate generation was lower than normal, and yet the bicarbonate went up. Where's the source of bicarbonate? You have to immediately think of a transcellular source. It had to be coming from cells. And so how would it do that? As I mentioned before, whenever you get potassium hydrogen exchange, you can't just think of that. So whenever you think of potassium going into cells, which we think about clinically sometimes when we're thinking of hypo or hyperkalemia, you have to ask, how did the potassium go into the cell? It can't just go as a cation, just like we talked about with the diet. It has to either be exchanged with a monovalent ion, like a proton or sodium, or it had to come out with chloride. Or it could have come out with an organic anion, like lactate or something else. But you have to maintain electroneutrality. So for the rest of your fellowship and when you're attending, don't just talk about one ion. You should start thinking about always coupling things together, because you're going to miss things if you just focus on one. And obviously, you're missing 50% of what's actually going on in your patient. So in this particular case, with potassium coming out and a proton going in, that could have been one source. Obviously, if K is exchanging for sodium, it's not going to affect your acid base. Or if K is coming out with chloride, you're not going to have bicarbonate transcellular shifting. But if you have K coming out in exchange for a proton going in, that's going to leave a bicarbonate ion, or generate one bicarbonate ion in the extracellular fluid. And obviously the converse could occur. K could go in and a proton would go out, and that would acidify your ECF and generate one bicarbonate ion in the ICF. But in our particular case, we can hypothesize that maybe this was the source of bicarbonate. And again, as I said, to the extent that sodium is exchanging for K, you're not going to make as much bicarbonate. And in reality, all the processes are occurring. K is coming out with chloride, K is coming out in exchange for a proton, K is coming out with sodium going in. It depends on the organ and the cells or the tissues you're talking about. But in the real world, it's highly complicated. Now let's do some math. So to calculate the cellular bicarbonate shift, first let's calculate from this study how much bicarbonate was added to the apparent bicarbonate volume of distribution. So you first have to know in a human being how to calculate the apparent bicarbonate distribution or bicarbonate space. And this is an equation which you're going to need to know clinically, because when you give bicarbonate IV to correct a metabolic alkalosis, you have to know where the bicarbonate's going. And because it goes into the whole body, it's not quite 42 liters, and it's not only the extracellular fluid volume, it's not only your blood vessels, it's not only the cells. This is an empirical equation, but it's useful. It needs to be modified in metabolic acidosis. That's why the bicarbonate concentration itself is in this equation. It's not physiology. This was created by observing what happens empirically to patients given a bicarbonate load. So it's 0.4, this constant, plus 2.6, another constant, divided by whatever the bicarbonate concentration happens to be, times the body weight, not the body water. And when you do this, this tells you the answer is in units of volume. This tells you the volume that your bicarbonate is going to go into. So if you take this volume and you multiply it by your initial bicarbonate plus the bicarbonate added, over this term, you'll get the final bicarbonate concentration. So you can flip it if you know this and you know the initial. You can just reverse these, do a little algebra, and calculate how much bicarbonate had to have been added to take the bicarbonate from the initial to the final value. So when you do that in this study on the low sodium chloride diet, the bicarbonate increased from 23.5 to 31. And calculating the volume of distribution, we can calculate that 203 milliequivalents of bicarbonate had to have been added. On the high salt diet, only 72 was added. Okay, so this is the total amount added. We don't know if it's coming from the renal vein or it's a transcellular shift. We just know that this amount of bicarbonate must have been added to get these concentration changes that they reported. So much more bicarbonate was added on the low salt diet. Okay, so now we want to calculate, was there any bicarbonate shifting from the cells? And you can do this clinically, by the way, if you really felt like it. You take the total added minus the external cumulative proton balance. So the total bicarbonate added includes the amount coming from the kidney, bicarbonate generated, which is this term, plus what came from the cells. So first, we need to calculate the cumulative proton balance. So we take the daily acid input minus the output, or if you want, the bicarbonate generation. And these numbers were available in their paper. And so on the low salt diet, the H out minus the H in is 8 milliequivalents. And therefore, 8 milliequivalents of bicarbonate were added from the kidney. On the high salt diet, your H out is less than your H in. Okay, and I know this is confusing and it's hard to memorize what was said, but I just want to briefly go over the thinking with you if you ever want to figure this out in the real world, or just for, intellectual pleasure to see if you can do it. So therefore, 169 milliequivalents of bicarbonate was actually consumed, because this is in the wrong direction. So on the high salt diet, we calculated the kidney actually consumed bicarbonate. It's the opposite of what we would think. So when we calculate now how much bicarbonate was added from the cells, on the low salt diet, this is the total. We subtract 8 that was due to the kidney, and we end up that 195 milliequivalents of bicarbonate to make the bicarbonate go up in those patients on the low salt diet actually came from cells. Did not come from the stomach, it did not come from the intestine, and it did not come from the kidney. It actually was a transcellular shift, likely in exchange for potassium. So as the patients went on the low potassium diet and got potassium depleted, potassium came out of their cells in exchange for a proton, leaving behind 195 milliequivalents of bicarbonate. That was the cause of the metabolic alkalosis. Highly surprising. They didn't do this in the paper. I just did it for today for just to show you how to go about the thinking. And then on the high salt diet, 72 half milliequivalents of bicarbonate were added total. But we have to subtract 169 because the kidney was doing things in the opposite direction. And so we end up with actually 241 milliequivalents of bicarbonate were added from the cells, and the kidneys actually consumed 169 of that, leaving only 72 added to the blood. So the kidneys are actually countering the metabolic alkalosis here that would have occurred had the kidneys done, what they did on the low salt diet. So the conclusion is that in both patients, or both types of humans, whether they're on a low salt diet or a high salt diet, when they're made potassium deplete from just cutting back on the potassium intake, the bicarbonate, when it becomes elevated, is becoming elevated because of bicarbonate shifting. That's the mechanism of the metabolic alkalosis. It's a transcellular shift. So again, just showing you pictorially what's happening here. On the low salt diet, 203 milliequivalents of potassium were added, 195 from the shift, K proton shift, and 8 from the kidney. Whereas on the high salt diet, only 72 total were added. Actually, the cells released 241 from the KH shift, but the kidney consumed 169, leaving only 72. So very sort of interesting when you look at all the inputs and outputs here. And now in the last few minutes of the talk, I want to talk about aldosterone, because that will come up too. Some attendees will say, yes, the high mineralocorticoids that are causing the metabolic alkalosis. But there are some surprises with that too when you actually look at the literature. So here's a very important study where they looked at the role of mineralocorticoids, and paper was back in 1970. It was really the first to look at it in a systematic way. William B. Schwartz was one of the fathers of acid-base balance. He and Relman came up with all the rules that we talk about in studies that were done. That if you're ever interested in going back and you're wondering where do all these compensatory rules and the rules for acute and chronic respiratory acid-base disorders come from, it was essentially William B. Schwartz and Relman who was not on this paper. Okay, so on the pathogenesis of metabolic alkalosis and hyperaldosteronism. Now, we do know clinically, or it was known at the time, that patients with primary hyperaldo can sometimes have a metabolic alkalosis, but as it turns out, many patients do not. And it's also been proven very difficult, even given large doses of DOCA, which is a mineralocorticoid, to generate more than just a mild metabolic alkalosis. And in this particular study, they gave a milligram of D-aldosterone daily, and you can see the bicarbonate, the average here is what, 1 milli equivalent per liter higher. So if it was 24, it went to 25, or if it was 25, it went to 26, very minimal. And the potassium did go down, as one would expect, as the cortical collecting duct and connecting tubule secrete more potassium into the urine. So there was a decrease in potassium, but the bicarbonate hardly changed. And yet, we think of hypermineralocorticoidism, primary aldo, and other states as a cause of a chloride-resistant metabolic alkalosis. So this study was one of the first to show that aldo per se doesn't do very much as far as acid-base balance. They hypothesized that there must be something else going on, and what they thought it was maybe the severity of the K depletion correlated inversely with the severity of the metabolic alkalosis. So maybe patients for the same amount of aldo who lost more K or had a lower plasma K had a higher bicarbonate. And so they went back to patients in the 1950s and went through all patients that they could find till 69 for this paper, and did indeed show that there was some correlation. Patients that had the lower potassiums, and again, we're mixing terms here of K depletion and hypokalemia. They didn't have K balance to be able to say there was more or less K depletion, but they went by the plasma K. And the assumption was the lower the plasma K, the greater the amount of K depletion. By K depletion, it means how much potassium was lost from your body, which you get from comparing the intake to the output and summing those differences over the course of when you decide to make your measurements. So that's what cumulative K balance means, or cumulative balance of anything, is input minus output each day, sum all those and find out how much was added or removed from the body over that period of time. So what you see here is that the lower the plasma potassium, the higher the bicarbonate, the greater degree of metabolic alkalosis. And so that went along with their thought that even for the same aldol level, somehow the lower potassium is creating a higher bicarbonate concentration. And Holter, who worked with Sebastian also in the 70s, looked at this in dogs, and paper was called K deprivation potentiates renal alkalosis producing effective mineralocorticoid. And what they did was the same as the other Sebastian human study. They did a K phos for sodium phos swap in the diet. So again, there were changes in sodium intake, but there were no changes in chloride because they didn't do potassium chloride deprivation. And what you see here is this was on normal dietary K intake. They gave the dogs deoxycorticosterone, and the bicarbonate goes up a little bit. And the K in these animals was 2.7, the average K. Whereas on the low potassium intake, the K went lower, as you might expect. And giving the dope, the deoxycorticosterone, the bicarbonate went up a lot more. And what you can see here is, so the question is, again, is this coming from a transcellular shift? Is it coming from the kidney? What you see here is that the net acid, we won't go into the component. Again, net acid excretion is ammonium excretion plus titratable acid excretion, which is, so this is NH4 plus H2PO4 minus, and you subtract bicarbonate if there's any bicarbonate in the urine. Here, the urine pH went down, there's very little. So basically, it's this plus this, and this plus this also equals the amount of new bicarbonate generation. And so you total them up and you get this term net acid excretion, which remember is equal to new bicarbonate generation. But the kidney, you can see that there's more new bicarbonate generation than before. So again, they hypothesized that it was the kidney. You would have to go through all that thinking that I showed before to see whether there's any transcellular shifting of bicarbonate or KH exchange that's occurring also, or whether the kidney is the sole source of the bicarbonate. But the bottom line is that hypokalemia and mineralocorticoid together seem to exacerbate, just like hypokalemia or potassium depletion, which would be a more exact phrase, in the presence of decreased sodium chloride, exacerbate the bicarbonate. Potassium depletion with mineralocorticoid together exacerbate the elevation of bicarbonate. Aldo alone or mineralocorticoid alone just doesn't cut it. Potassium depletion alone on a normal sodium chloride intake doesn't cut it. You need to combine factors together. That's sort of the themes that were emerging at this time. There was another study looking at another set of parameters. You could think of this as Venn diagrams, looking at mineralocorticoid, but looking at the effect of sodium chloride intake, not potassium per se. And what they found, this was way back in the 1950s. But what they found was Selden went on to become the chairman of medicine at Southwestern. Now, there's an interesting video of him prior to his death in the JCI, if you want to look through his history. He was one of the thought leaders of understanding of fluid and electrolytes and acid base in the 20th century. But at any rate, what you can see here is that on a low sodium chloride intake, there's a higher bicarbonate concentration, slightly higher. And so the thought was that from this study that mineralocorticoids or the bicarbonate concentration is affected by mineralocorticoids and sodium chloride together. So potassium depletion alone, mineralocorticoids alone, not shown here, sodium chloride intake alone, but anything alone doesn't seem to cut it. You need to have combinations thereof. That's what these these and other studies showed. So the take-home points: effective mineralocorticoids alone to elevate your bicarbonate is mild to absent. The effect varies with the magnitude of the K intake, and also it varies with the sodium chloride intake. And remember that if you have potassium depletion, the bicarbonate, if you superimpose on that a low sodium chloride intake, you will also elevate the bicarbonate more. So combinations of these factors. Over the next number of weeks, we'll talk about the role of chloride. We'll talk about the volume status and some of these other things, including at the end, renal, take it back to the clinic. So what is actually going on in Bartter syndrome will be the topics at that time. Which of these factors are actually coming into play? Is it aldo? Is it potassium? Is it something else? These kind of things. And prior to that, we'll talk about also the nephron transport machinery that's involved with the clinical phenomenology. So I think with that, we'll stop today, and we'll carry on in the next few weeks with metabolic alkalosis and some of the parameters and subtleties that go into the thinking behind this very complicated acid-base disorder. So thanks, everybody, and have a great rest of the day. Unless anybody has any questions, be glad to answer. Okay.